same as the texture of your skin or your mucosa. So if you can get through suture pads, you do great on a patient, okay? The only thing about patients to think about is you don't have that much space, you know, to move around. So you get used to it eventually. Who does not know anything about suturing? Good. So my aim is to, at the end of this class, make you comfortable with everything that has to do with suturing and sutures, okay? If you have any questions, please feel free to ask, okay? This should be a short class, so I need your attention, okay, and participation. Let's do this together. Got it? Everyone on board? Excellent. My name is Ayo. So I'll and I'm going to do by 3.
Let me add one more thing, Ayo. You guys have this additional resource I sent to the class. There was an additional PDF of certain pages for suturing only. Can someone verify? I mean, I hope the whole classes are here. It says John's Journal of American Orthopedic Surgery, like this, a publication of our monthly journals. Additional publication for suture. Yes, everyone has it? Yes, okay. So again, the goal of this is not to replicate something I gave you guys already. So there's going to be questions from that. Let me see. Yes. Let me see. No, it's actually, it will say John's. John's Practical Guide to Suturing. I did send it. Okay, I will resend it if you guys can find it, but this was sent in the beginning with all the additional material that is not on Vital Source. I don't want to take time from Dr. Ayo. Anyone can find that? Or I'm going to resend it. I don't want to take time from it. Resend it, please.
Okay, so hopefully at the end of this class, you should be able to discuss the functions of sutures, what sutures do, describe the tools you need when you're going about to suture someone, and demonstrate familiarity with common suturing techniques. We're not going to go advanced, we're going to go into the basics, okay, for this class. Again, what is the primary role of sutures? Anybody?
To close.
To bring tissues together, okay? If you understand that concept, you know what we're talking about in this class. Sutures are just to bring tissues together, and by bringing them together, you close holes or, you know, spaces. So it's approximating wound edges or coarctation of wound edges, promoting healing by primary intention. That means when mucosa comes together edge to edge, you can have primary closure without formation of a scar, an obvious scar. And then to minimize the space between wound edges faster and between healing. In the setting of trauma, we need sutures to bring together tissues that have been torn apart and lacerated, one thing or the other. They also help in hemostasis. When you reposition the flaps, you are able to reduce the bleeding. One thing of note though, please make sure you control bleeding before you suture, okay? Otherwise you can have that area just pool and hematoma forms there. Who knows why hematoma is dangerous? There are many reasons, but you can give me a reason why hematoma is not a good idea. One, it's a breeding ground for infection. So all that surgery you did is going to get broken down because infection can start. These are questions we may ask behind having your exams, like, hey, well, you know, why is hematoma a bad thing? You know, what's the complication or sequelae from hematoma formation? It's infection. Why else is hematoma bad? Because it's obstruction if it happens on the floor of the mouth. Because it's respiratory obstruction, and we don't want that. So control your bleeding before you put your flaps together. It also helps maintain or stabilize the clot. If you notice when you do an extraction, you can do a figure of 8 suture. We'll go over what that means. And then over the flap, while you have your suture material in, your hemostatic material in, your sutures help keep it in the sockets while the area heals. So let's go straight to the instrumentation. Who knows what this is? You guys have gone through it already. Bite blocks, right? This is a type of bite block. What type of bite block is that? There's a longer bite block used for edentulous patients, right? Have you guys seen that before? Yeah, so if you have an edentulous patient, you probably won't use any of these bite blocks. You use a longer one because they don't have teeth, so it compensates for the fact they don't have teeth. So it's a little longer. And how do you place these in the mouth? What part goes to the posterior, what part goes to the anterior?
Yeah.
The smaller part goes posterior, right? Because your mouth opens like this. Think about it, right? So this is going to fit best with this part, the smaller part going in the posterior, and this. Okay. And what part goes to the buffalo? What part goes to the lingual? This one or this one?
The top goes to the buckle.
The top goes where?
Buckle.
To the buckle. So it keeps the cheek away. Good. Very good. So now we want to try to place these things in the mouth correctly, right? Anyone confused about what I just said? No, good. And then you also have different types of mouth props. It's another one, the mouth prop can be used. I think we have that here. I've seen some people use that to just keep the mouth open, keep the cheeks retracted.
Typically, whether used for sedation cases where you have to forcefully open the mouth, if this plastic is not there, it hurts. So we have some that the plastic is not there, so try not to use it. This plastic cover is very important, otherwise it's meant to teeth and cause injury. So yeah, it's a useful thing to have in the office, especially if you are doing sedation. Yeah.
And there's a U-shaped one that comes, cheek retractor comes and you use under the chin. So it's important to be able to retract tissues out of the way so you get suture. So that's why this is important. Let's have other retractors. Who's familiar with what this is? Just in case you see that in your steeplechase or what do you call it now? Surgery walk, upper surgery walk and stuff. What is this? It's an Austin retractor. What is this? You guys have seen that a lot. It's a Minnesota retractor, right? And what is this? A weeder or a sweetheart. Good. Good. All these help retract tissues. The sweetheart is usually used to retract the tall tissue out of the way, like you can see in this picture. The Austin retractor can do tongue or cheek, and the Minnesota is usually used for the cheek. Another thing that's important in suturing is tissue forceps. We have various types of tissue forceps, right? The top one, who knows what this is? It's called an Addison. Have you ever heard of Addison forceps? That's what they refer to, okay? And then the bottom ones, still these, the ice is kind of here. So let me give you guys a hint, right? And you have the angled ones as well. The angled ones is used for, it's very good for picking up objects or things. This good for tissue and for suture, and this for tissue and suturing as well. Note how the teeth look in these instruments. What is this called? Alice tissue forceps. Notice the teeth. You see how it grabs tissues. We're taking out like a soft tissue lesion, for instance, and you're trying to dissect out a soft tissue lesion. You would grab it with an Alice tissue forceps and hold that to retract out the tissue while you incise and while you're closed. So note how the teeth looks on the Alice tissue forceps versus the Addisons. And that's why they're used for what they're used for. Tissue, and this one holds tissue with more gentle teeth. Some of them don't have teeth at all, so you can request Addisons with teeth or without teeth. Okay? And then very key is your needle holder and your hemostat. Now, there's a difference between a needle holder and a hemostat, and this comes out in exams a lot. Like, how would you differentiate the needle holder from the hemostat? One of the ways is their beaks, the size of their beaks, and the anatomy of the features on their beaks. So when you see this pattern is called cross-hatching. Okay, cross-hatching. And why is that important? Does anybody? Grip. Cross-hatching is important for grip. This is what helps you hold the suture. So when you see someone give me this to do sutures, I'm sure they don't know what they're talking about because they don't, you have to look at this. This doesn't grip the needle well. Because it's linear, it has vertical, horizontal lines. They don't grip. They're good for tissue. They're good for blunt dissections. They're not great for suture. Okay? This is what you want, something that has this cross hatching. It's good for grip. This is how the needle holders look on the tips. Now, importantly, how do you hold a needle holder? Has anyone held a needle holder before, or scissors to cut or cut to go into someone who's working? Yeah. What's the important thing about what hand goes into the holes? What finger goes into the holes?
Thumb and middle
The
finger.
thumb and your ring finger. right? That frees up what? These two in the middle and this one at the back for stability and direction. So every time you hold, practice this at home. If you have a pair of scissors, grab it with your ring and your thumb. And you have this pointing upwards and this supporting it on the side. Okay? Thumb, ring finger, these extra for stability and direction of your instrument. Very good. Now, how do you hold, what are these things called? Not a trick question.
Suture needles?
They're called suture needles, right? Suture needles. And you can see they have different configurations. This looks like a half circle, right? And this looks like less than half of a circle. That's called a 3/8 type needle. They're 8 type needle. And then you can notice that the cross section of the needles have different configurations. What do you notice about this needle? Where's the sharp end? Is it on the concave or the convex part? This is the sharp end, by the way. So it's on the concave part, right? Sometimes it's reversed and the sharp part is on the convex part. Make sense? This is an important distinction to know when you have the needle. You read it, is it cutting? Is it reverse cutting? Okay, we're going to go into that in a little more detail later on in the class. But if you figure it into this triangle, it tells you where the cutting part is. So where's the cutting part of this needle? Concave or convex part of the needle? Concave. Concave. Is everyone clear about that? Is anyone confused about that important point? Okay. We'll test that. And then notice how the needle holder grips the needle. Where does it grip the needle? Toward the end, right? Away from the tip of the needle. But not on the point where the needle meets the suture. Clear? Good. Now, when you do competencies for suturing in the clinicals, all these things I'm talking about are on the grading sheets. Would have to test you and give you some points based on what you did right. Don't do these things just the way I just described them. Hold your instruments the correct way. Load your needle the correct way. Making sure that the needle is at the tip of the needle holder, not here, not here, but at the tip. And it's angled in a way that you can actually suture and see what you're doing. You don't get points. Is everyone clear on the slide? Any questions so far? Good. The different types of sutures, you would encounter this. Sometimes they ask, give me a silk suture, give me a chromic gut suture, give me a fast gut suture, give me a nylon suture. You know, all these sutures are different types based on if they're absorbable, non-absorbable, monofilaments, polyfilaments. Absorbable means that they tend to degrade over time, okay? Non-absorbable means they do not degrade. And so we may have to go back and take them out once the tissue has healed. Clear? Monofilaments means that they're not woven. It's just a single filament. The advantage of this is that they don't tend to absorb bacteria. But also the disadvantage of this is it's harder to work with. And you don't have a lot of grip when you tie your knots. So that's it about monofilaments. And then the polyfilaments are easier to work with, but they tend to wick or trap bacteria in the saliva. And so that they can cause more infection the longer they stay in the mouth. What we typically use in the mouth are chromic gut sutures, 3/0, and silk sutures, 3/0 as well. But silk sutures, you have to take them out because they wick and they don't dissolve over time. So you gotta take them out. Chromic gut sutures in a week or so, they tend to dissolve. So you don't have to take them out. And this is what a chromic gut suture looks like. Each of these things on the package means something. This, what does it tell you about the needle? It's reverse cuts, right? Where is the cutting side? On the concave or the convex part? On the convex, right? It's on the outside. So unlike what we saw, those are the concaves and the convex part. Good. And then this is the exact size of the needle inside. So it tells you the exact the size. Exact size of the needle inside this package. It tells you that's how thin the needle is. 27 inches, 7 centimeters, that's how long the thread is. Okay? It tells you that it's absorbable as a property of the suture itself. So everything on this stuff means something. Whenever you open a package, look out for what the description is saying, because that's key. Okay. Now, how do you open a suture material? This is key. Dr. Dublin says, give me a suture and open that for me. How are you going to open it? You grab the package by the edges. You see the edge, and you show it to the surgeon so that they can pick it, because the inside is sterile, the outside is not. Got it?
We covered this in the first lecture, right? Learning and nothing, how to open a suture material dropping on the sterile nail, right?
Yeah, so this is a good refresher for you.
See, sterile glove, the hand is taking the inside content while the person who is opening the outside, bare hands. When the circulator nurse opens this in the OR, that's exactly what happens. And you can do the same thing in your treatment room.
Clear so far? Good. And how do you load the needle? Remember I taught you, okay, tell someone bold enough to how do you load the needle? Based on what we talked about previously. How do you load the needle? So the two head on the tip, right, and of the needle holder, and then what part of the needle do you hold? You grab.
Did you talk about swage?
We'll get to that.
Yes, we did.
We'll get to that shortly. Next slide. But I showed you where to hold it, right? Right? Away from this junction here and far away from the tip. Like 2/3 of the length away from the tip is where you hold it. Very good. So now let's go to the anatomy of the needle. So what the needle looks like, it has a tip, that's the points there. The thing to know about the tip is not all sutures have a cutting tip or a sharp tip. Some sutures just end in a taper. Okay? Sometimes they end in a point where it cuts through tissues. So there are different types of tips. And then you also have the body, that's from the tip up until like 2/3. And then the remainder of the 1/3 that connects with the suture is called the swage. So the tip, the body, the swage, the parts of your suture needles. And you have different types of curves. You have a quarter curve, you have a 3/8, the half, 5/8. The 3/8 is the most common, and you have a half as well. The important thing about the type of suture is it tells you how to turn your wrist, how much wrist turning you do when you engage the tissue. And next slide we're going to look at how to position your tip, the tip of your needle against the tissue. So again, we've been through this, right? The reverse cutting, the cutting is on which side? Convex. It's at the back. It's behind. It's the convex part. Conventional cutting, the point is on the concave. Good. You have a point, you have a blunt point. That's the tip. You see how this tip doesn't have a point? It goes to the tissue. So it doesn't tear the tissue. If this tears the tissue, you gotta be very careful because it's a sharp point. If this hits bone, the needle's gonna bend. So you gotta be careful with that as well. Again, talked about the different sides. Now, how do you use a suture? It's the correctly positioned needle holder on the suture needle. Now, how do you position this on the tissue itself? What's not shown here is your use of your forceps. You use your forceps on your non-dominant hand to grab the tissue you want to suture, and you use that to reflect the tissue so that you can easily pass your suture through. The aim is to make sure that the angle is, what do this angle is? Right. It's about 90 degrees, right? Yeah, you don't want it to be acute. The more acute it is, the less likely it's going to engage more tissue. So this is wrong. Okay, you want it to be at about 60 to 90 degrees. Okay, according to the text, 60 to 90 degrees, preferably 90. When you engage the tissue, and what that does is it makes sure that you are cutting through the entire tissue at the exact location that you're entering it. If you come in at an angle, you don't grab onto the tissue, you shear the tissue. And you hear people say, "Oh, the suture pulled out." That's because the angle at which they went in was not favorable for grabbing the entire tissue. So be careful. And this is what come out. Just letting you know. The angle is important. And that's something that you must always do. Now, when you put your sutures in through the tissues, we do multiple types of ties. The most common ones are the interrupted suture techniques. We'll talk about that shortly. The continuous suture technique, the horizontal mattress, and the figure of eights. These are the four most common ones that we typically use. There's tons of others. But these four you must know well. And whenever you are suturing, you make a decision as a surgeon to determine what is best for closing the site. Also, we're going to talk shortly about the instrument tie. How do you do a good instrument tie using your instrument? How do you do a good surgeon's knot? And where should the surgeon's knot be placed? Where should the knot be placed after your suture? So let's go straight into it. Now, this is an extraction socket. We're missing here, here, and here. When we want to close this tissue, our primary goal is to put the papilla back together. So we come in from the buccal, the tissue, and we go in to the lingual. When we tie our knots so that the knot is not resting on the wound edge, but away from it. You move your knot away from it. What happens if you leave your knot on the wound edge? Say it again. It won't heal properly. It will irritate the wound edge because it's serving as a foreign body and it's applying pressure on it. So you want to move your knot away from the wound edge to the side. Now let's go into a little more detail. How do you make this knot? What are the steps that you take to make this knot happen? The first thing is you go in buccally, like you can see here. You grab the suture needle with your forceps again, your tissue forceps, and then you reload your needle to go in to the lingual aspect and engage the lingual aspect. Next slide, we'll talk about how you make your surgeon's knot. So how do you do your surgeon's knot? What do you notice about the shape in A? What shape does this form? Does the needle form when you've gone through both buccal and lingual tissue? It forms a V. Okay? This is key. It forms a V. Where does your instrument go? In the middle of the V. You would see, sorry to say, me, or sometimes other people, other surgeons, would do things, the way they feel comfortable. But this is the proper way to do it. Your instrument goes in the middle of the V. And what is the goal? You're going to wrap this thread that contains the needle around your instrument twice. And then grab this end here and pull it to the opposite side. Got it? While your non-dominant hand moves to the other side. So at the end of this, see, the V is wrapping twice for the first knot. And then when he's done, you see how this hand moves over to the other side and the instrument moves to the opposite side? Does it make sense? So we have a V, right? The instrument goes where? In the middle of the V. If this is the needle, what side am I going to wrap over the instrument? The side with the needle. Got it? Because this is the shorter side. I'm going to wrap the longer side, which has the needle, over the instrument twice. And when I do that, what's my next call? To grab the shorter end, right? And pull it where? Here. While this one goes where? Here. You see how I form a square knot? You see how my hand is square now? That is exactly how suture should be done. Okay? So now you have another V. Where does the instrument go to complete the knot? In the middle of that V as well. And what do? The opposite of what you did before. So you move this is the long arm now. Move the long arm over the needle once. You grab the short end over to the other side where it started off in the first place while the other one comes through. You go in the V again to complete that motion. So you're always going back, forth, back. Suture is a very beautiful thing. But if you understand this mechanism, you will not forget how to suture. It's not that complicated, right? Okay, let's do it together. You grab your needle, you thread it through buccal, lingual, papilla, right? You have a V. You have a short end, you have a long end which has the needle, correct? Your instrument goes where? In the middle of the V. And what are we doing with the long end? We're wrapping it over the instrument. The first knot is twice over the instrument. So it goes one, goes two, right? And then you use the end of your needle holder to grab the short end and bring it where? Across, while your hand moves the other way. So you have a square knot, okay? You tighten that, but now you're on opposite end. So you go where again? In the middle of the V. And you do that motion in reverse. Now this time, your needle containing suture is on your other side. You wrap it around once. You grab the short end to the side while your hand moves here. That's your other square knot, okay? You repeat that process again one more time, or two more times. Back, forth, and that's how you suture. Is everyone clear? Who is still confused? Yes, go ahead. Oh, okay, what are you confused about? What would you like me to go over? So after you have the long end and the short end, is that after the first pass or the second pass? The first one. So the first pass, the short end, let's use my right hand, right? The short end is my right hand, the long end is my left hand, okay? Is that clear? So my goal is to wrap the long end over my instrument twice and bring the short end from the right to the left while I bring the longer end from the left to the right. That will give me a square knot. Okay, so let's go over it again together. I have a V, my instrument goes in the middle, I have a short end and I have a long end. The goal is to wrap the long end over my instrument twice. Grab the short end and bring it to the right, to the left, and bring the left hand to the right. So I have a square knot. Good. Now I have another V. And every time I'm wrapping what? The suture containing end on the instrument. To bring the short end from wherever it is to the opposite side. And bring that suture end to the other side.
This is called alternating. You alternate each time, right? Tail is the short end. When he says V, it's a V, but the one side of the V is the long end of the suture. The short end of the suture is called the tail. The tail is the short one. So each time you alternate as you crisscross. So if you look someone who does it, you will see the arms alternate, right? Because for you to put the tail from right to left, and then in the next knot from left to right, and in the third knot from, again, where you are to the opposite side, you kind of crisscross, right? I mean, that's how it will look. That's why somebody needs to retract, because you need two of your hands. You cannot be retracting the cheek with a Minnesota retractor, have a needle holder in your hand and do it. You need two of your hands, because you're going to cross, alternate from one side to another. Now, this is based on 3 knots, right? Because 3 knots is minimum required to secure it, as he well explained. You're making knot, right? 3 knots. When it's finished, it's a surgeon knot. There are many, many types of knots, which you will have a lecture at hands-on by me on the 3rd year. But say you want to do 2 more, right? You just sometimes, if you're afraid it's going to be early, instead of doing 3 knots, you put 5 knots, right? Depending on the suture material you use, what you are closing, multifactorial. You will continue to the 4th and 5th one exactly by alternating, okay?
Yeah.
Hope that clarifies. Now, of course, we're going to watch videos on this, right? This is the lecture, like
We're going to have labs on it. We're going to have labs.
We're going to have practical too, but at this point, after covering this lecture, you're going to look at the materials I gave you, because some of the resources I sent to the class have very good different visuals, right? This is great, but then this is really not enough, right?
It's static.
This is main, yeah.
It's
You're
not
going to open those pages because they are meant for you to visit multiple times, more times than you visit your TikTok and Instagram accounts, to make it yours, because there are very good visuals, okay? And then once you do that, there is something called, educational resources as videos available, right? Rather than watching the drama, you're gonna watch the videos, right? That will actually, you're gonna connect them.
Yeah, go ahead.
Could you go over the directions? I know it's sometimes clockwise.
So I don't want you to think about it as clockwise, counterclockwise. The goal is, the way to remember it is you are wrapping, you're in the middle of the V, you're wrapping the suture containing end, the long end, over the suture.
We teach that way in the upcoming classes, so it's better to use it
But
because.
yeah, so first time is clockwise, second time counterclockwise. But it gets confusing for me to see what's clockwise, might be clockwise or counterclockwise. If I'm in the middle, right? If I have a V in the middle, I know this is the long end, I have to wrap it this way. That's counterclockwise, but I know I have to wrap it this way. Next time, this needle long part is going to be on this end. So what's what doesn't happen? Wrap it this way. So you're alternating the way you're wrapping it based on where the needle is. The needle's always in the V. You never miss it, but it's clockwise, counterclockwise, clockwise.
So that applies to the direction you put the long suture over the needle holder. So the only instrument in between the V is needle holder, right? Not the hemostat, not anything else, not adson tissue forceps, it's the needle holder itself. The one that allowed you to put the suture needle there in the first place. Once you are ready to tie the knot, then that instrument gets placed in between. And the direction, clockwise and counterclockwise, is actually written on their suture competency grade sheet, because to do it like for this to be a secure knot, the way he described, to be a surgeon knot, the direction of how you put that long is important, right? But as he said, like, it's not the only thing, you know, you will pay attention to where you are, what you're doing, but the long tail, the long suture, the first one is clockwise 2 circles, and the second knot is a counterclockwise 1, and in the third one, clockwise 1, okay? And that's written on the competency grading worksheet also for sutures, and it is written in here in every resource I gave you, yeah?
On the competency sheet also, they'll ask you, you'll be graded on how you protect the needle when you're suturing. Notice how this needle is protected. It's not grabbing a tissue, grabbing the eye, or anything dangerous. So it's important to protect your needle when you're doing all these motions so that it's not hurting the patients or harming the patients. And you're surprised how often this happens. Yeah, get dinged for it. So we've gone over this. This is what's going to be a square. If you follow those instructions, yes. Say again.
When is it transition from instrument tie to surgery?
So when you use your instrument to make the tie, it's called an instrument tie. The first knot, double one, is called a surgeon's knot. But you're doing it with your hand, with your instruments. I can do this tie with my hands without an instrument. I can do it single-handed or double-handed. So there are many ways to do suture. Sometimes you see me do hand ties because it's easier for me to do it that way. So that's called a hand tie. It's called an instrument tie if I'm putting my instruments in the middle, using my instruments to make the knots. The knot itself is called the surgeon's knot. Okay. So the thing you use to do the surgeon's knots could be the instruments or it could be your hands. Everyone clear on that now? Okay. So what if you have an implant there? How do you suture the papilla around the implant? You can do interrupted, so you can do horizontal mattress sutures around the implant. You go into this, there's a class on all these techniques, but I just introducing you to the concepts to let you know that you can do a various variety of techniques. It's all suturing, just bringing tissue together, trying to make sure it heals properly. What if you do a complex flap? You guys did the last lecture was probably on the complicated extractions and stuff. Sometimes you do flaps and releasing incisions. What is the sequence that you follow when you're suturing a flap that has a release? First thing to approximate is the release. Got it? So you do the release first, then you do the papilla. This the more proximal papilla and the more distal papilla, and then you go for the upper limb or the middle part of your release. Everyone clear on the sequencing? The first thing is to put the flap together, right here, 2, 3, and then you can go and finish up where you started. Very good. Now we do horizontal mattress sutures when we want to evert. This is what it means to evert. To evert the edges. So the edges lie like this. Tissues heal best when the edges are everted. If the edges meet like this, they have a tendency to contract and go in and dip inside, so they don't form a flat surface. When they're everted, when they heal, the scar down and they become flat. Got it? So the goal is really to evert your edges so that the tip of the edges is looking upwards. It will look weird, right? But when it heals beautifully because when the scar's down, it flattens. But if it's straight when you suture, the tendency that it's going to dip is high because it's going to scar down eventually. So to evert your edges, there's a technique called the horizontal mattress suture, which you will go into detail with in advanced classes on suturing. But the technique is you go in, buckle, come out the lingual, go in the lingual, come out the buckle, and then you tie. Okay? We'll go into that in detail later on. Again, you can use that same technique when you have defense, the horizontal mattress suture. You see, you go in, come out the lingual, go back in the lingual, come out the buckle, and then you tie this together. You have that. That helps you get your approximation if you have an implant. This is the continuous suturing technique. You tie your suture, do your surgeon's knots, do your instrumental hand tie here, and then you begin to walk your suture through each bucket, walk it down. And then finally you tie it when you get here, and you get this. It's going to look like this. Now, this is a different technique called the locking, running locking technique. We're not going to go into details today, but just know that this is a technique where the disadvantage of the running suture is if this cuts, what happens? Everything unravels because we just ran the suture, right? But with the locking technique, if this cuts, everything doesn't unravel. It stops here where you last locked it. So it's a more secure suture. But you go into these techniques later. Nothing to memorize. If you didn't get anything from this lecture, know this. Enter needle at how many degrees? 90 degrees, right? To minimize damage to the tissues. Avoid tying too tight. Why? It's going to cut off the blood supply to the tissue. It's going to cause tissue necrosis. It's not going to heal properly. Okay? And then make sure you apply, make sure you get hemostasis before you close. Why? To avoid hematoma formation, right? Okay, hematoma leads to infection, and it's on the floor of the mouth, airway obstruction. You don't want those, right? Good. And then for non-absorbable sutures, remove them when? For non-absorbable sutures, remove them 5 to 7 days. Why? Because it can cause infection, right? You know, sutures like the polyfilament ones tend to wick saliva and bacteria. So they keep bacteria close to the wound edges and can cause infection secondarily. Yes?
Did you say the silk ones are?
They're wicked. They're polyfilaments.
And then the gut one, chromic
The gut one is also a polyfilament.
Oh, they are?
But it resorbs, silk doesn't. So silk you gotta take out. Probably you don't need to because in 5 to 7 days it resorbs on its own. Clear? Good. Let's test how much you understand about this. So good surgeon's clothes means great surgeon's clothes, care, planning, and finesse. Let's look at a couple questions. What is the primary function of sutures in oral surgery? It's not to improve aesthetics. It's not to reduce bleeding. All these are correct, right? But what is the primary function? Is what? To bring the edges together, coaptation of the edges. Very good. Very good. Why should sutures not be tied too tight? Just kind of going over this. Why? Anybody? It can cause ischemia and tissue necrosis. You understand the mechanism by which this happens, right? It strangulates the tissue. So it cuts off the blood supply to the tissue so they die. Don't tie your sutures too loosely or too tight. Just make sure they're firm. Bring the tissues together, it will not fall apart. Very good. Very good. When placing sutures, the needle should enter the needles at what angle? 60 to 90 degrees, preferably 90 degrees. Very good. What happens if it's 30 degrees? The needle will come out, will fall out. What else? Causes more tissue injury. Just think about it. If I'm going through the tissue at 90 degrees, the only part of the tissue that gets hurt is this part. If I'm going at an acute angle, what happens? I'm cutting off so much of the tissue before I eventually come out on the other side. So you want to go at the least traumatic angle, which is 90 degrees, 60 90. It's very good. What is the purpose of the figure of 8 suture in oral surgery? I said that's in the beginning of the lecture. So I'll just use suture the figure of 8 over a socket that I have put like a hemostatic agent, like collar plug or something in, because the suture helps to do it. Helps to keep it in, helps to keep the material in, right? An X suture is on like an X suture over socket. So let's see. Choose options sounds correct.
You put something you don't want it to fall. What would you put over it, superior to it,
Suture.
that that will prevent it from coming down? I mean, there are multiple ways, but in a single tooth area, that is why it is asking you to understand. Single tooth socket, you put hemostatic material, and then you cannot do continuous, right? You cannot do running locking because it's like one tooth socket, right? 3 interrupted will work, but that is, it's quicker and more effective if you do something that will put an X on the area to prevent anything from falling, which is the figure 8. When you do figure 8, it actually creates a cross, right?
So it helps you keep your hemostatic agents in. So it aids in clot retention and hemostasis of the strap.
And closes the flap if you flapped it, right?
And it closes your flap because
Brings the socket together.
the 8, think about the 8s. The 8 is like this, right? Zigzag, zigzag. On it? The lines on either ends help you close the papilla. The X in the middle helps you retain what's in the middle of your sockets. Good. Which knot type technique is recommended to prevent loosening of oral surgical sutures? Is it the granny knot? Is it the uncle knot? Is it a one-hand tie? What is it?
Surgeon.
Okay, describe the surgeon's knot to me. Did I ask you? Because I can't describe it to you. What is the surgeon's knot? You guys are shocked. You know this. Thank you. Okay. Exactly. So you do a double clockwise, right? One counterclockwise, one counterclockwise. You secure the knots. Okay. So that is recommended to prevent loosening of the sutures.
What is granny? Just explain what makes a granny knot. Let's explain. It's if you actually continue doing it all in the same direction. Okay? So you do 2 loop clockwise, second knot, another clockwise, third knot, another clockwise. If you tackle multiple clockwise knots on top of each other, that's a granny knot. It will open. It's not secure. And I can prove, I prove it to the students when I do the hands-on lab, suture lab in the 3rd year. Okay?
I don't have a visual of what it looks like.
I provide the material, actually, magnification of the knot on the book.
But it doesn't form a square.
Right.
Because you're going in the same direction every time you do the knot. So it doesn't secure the knot.
A square knot is known as a surgeon knot, is known to be the secure knot. Granny knot is not a secure knot, it will open up.
All right. Good luck with everything. Any last questions? Everything good? All right. Thank you.
You're welcome. Thanks,